Hello, everyone, and welcome to this weedy virtual spotlight, provider data management, breaking down silos to create a single source of truth. This spotlight is sponsored by InterSystems. If you have questions at any time during the spotlight, please use the chat feature in your Zoom toolbar. It's my pleasure to introduce a product manager with InterSystems, today's presenter, Kristen Nemes.
Hi, Michael. Thank you for that introduction. And it's great to see everybody here, have this sort of gathering and meeting of the minds of people who are hopefully just as interested in and passionate about provider data management as I am. So with that, I'll get started here, and please feel free to interrupt me with any questions, or you can feel free to put them in the chat for later. I hope to have a lot of time for question and answer at the end of this. So, yes, as Michael said, my name is Kristen Nemes. I am the product manager for the identity data management portfolio at InterSystems. So that includes our health share provider directory product. But today I wanted to talk a little bit about the need for accurate provider data and what that's doing in the larger span of healthcare, enterprises, and beyond here. So really tackling those silos that have accumulated in terms of data and being able to create that golden record, that single source of truth, so that you're able to operationalize a lot of your strategic initiatives with regards to provider data. So jumping right in, I wanted to start with a couple of imperatives for high quality provider data that I've identified. Probably some of these will resonate with you and your organizations here. Um, just quickly touching on some of these, right? Enhancing that patient or member experience, right? Gone are the days of getting referred to a provider and, making an appointment over the phone and showing up without any real background on the person. Patients and even members are doing a lot of research on where they get their care, who they get their care from, and they have really high standards for the type of data and the accuracy of the data that's going to be included for them, right? So a lot of times that initial touch point with your organization might be through your website. If you have a Find a Doctor portal that allows patients or members to search for care, that could be the first time that they're ever touching your organization, let alone setting foot through the physical front door, right? And it might even gate their, ability or desire to actually go and make that appointment and get care that they need. Um, we're even seeing, with the rise of AI and the large utilization of that by, the general public, you might even be searching for doctors on ChatGPT, right? Hey, I need, this type of doctor. I want one who is within a 10-minute drive of my house and also meets, my preferences that, you've known through getting to know me through my previous queries. So there's definitely a need to have that accurate data available and there for those patient or members or potential patients and potential members to have. And kind of hand in hand with that, right, is the prevention of these ghost networks, right? So kind of a new term that has popped up, but I'm sure everyone here can maybe relate either for your own care or that of your children, maybe an elderly parent. You look through a list of doctors, you find one that you like, you want to try to make an appointment. Oh, they're not actually accepting new patients, or oh, the phone number they provided is out of service, or oh, the person has retired. They're no longer practicing, right? So you have these networks that look really impressive, look like they have great coverage, but actually in reality, when you start to audit those provider data, data points, you're not actually able to get that. And then of course, provider utilization. For the providers that you do have that, have data there, you might have some that have a long wait list to be seen and others that have several appointments available for the same specialty. Can you control the way that your users, your patients or members are actually finding doctors and match them with doctors who are going to be able to get them care more quickly and maybe alleviate the burden from some of the other providers who have longer wait lists there? No Surprises Act, CMS 9115, these regulatory and legal mandates to have a readily available, regularly updated and accurate provider directory. There's, of course, penalties for not complying with that, but I think There's also many reasons to comply that are, separate from just avoiding a penalty there. Keeping referrals in-house. If you are a large, say, academic medical center, you have a primary care practice that's referring patients to a cardiologist, and the patient is going and finding, cardiology care outside of your own medical center network, right? That's missed opportunity, it's missed revenue, and potentially a delay in care, right? For the patient actually having to go to a totally different organization to get what they need when they could get it from somebody maybe in the same building as their primary care provider. And then star ratings. So CMS star ratings, I think, are a big topic. They're not directly influenced, in a one-to-one sense by having an accurate provider directory, but certainly the ability to access care in a timely manner, to have accurate representations of the networks and the care available for these plans is relevant and does affect those star ratings there. So I just wanted to sort of summarize why we're talking about this. I'm sure each of your organizations that you represent has their own why, and that's probably why you guys are here. So with that, I just wanted to set that context. Yeah. And so let's talk a little bit more about that digital front door here. So this is an example of a Find a Doctor service at one of our customers. This is just their public-facing website. And actually what I can do is I'll just pull up real quick what that website looks like today. If I can find this. So hopefully you can see this, right? So it's their Find a Doctor. This is branded according to their, style guides, things like that. Everything looks like it belongs on this page. But if we were to look at, browsing by all the various conditions that these doctors treat, I'm gonna choose diabetes, right? You get these this list of results, right? It's a very nicely formatted, it's pretty easy to use, and it has relevant information right there available when you need it. So let's say I'm looking for female doctor. Okay, there's a couple results there. Want one who's accepting new patients. And then within each field, I actually have more information. So here, this was sort of a general overview of specialty, maybe insurances, contact information. Then there's an opportunity there for a little bit more sort of public-facing narrative, right? So here's what I'm about, here's what I do in my free time, here's what I care about in terms of my practice, here's why I might be the right doctor for you, right? Procedures and conditions I treat, where I practice at, education, anything like that. So this is, the information that your patients or members will see when they come to your digital front door looking for information, looking for how to access care. So this is just an example here. I'm going to cut back to these slides real quick. And I think here I want to emphasize that a lot of the technologies we talk about for, the how we do provider data management tend to be very back-end oriented, but I don't want to lose sight of the fact that the end result is going to be very public facing, right? These are patients or members who, span all types of people, right? They could be elderly, they're not, super familiar with technology, could be one of their caregivers, right? So if you're caring for an elderly parent or a child, you have to navigate care on behalf of another person, or you're a care coordinator, right? Potentially a professional, maybe with a high caseload, and you want to be able to find the information that you need quickly and ensure that it's actually going to be accurate and actionable. So you don't want to be wasting time calling doctors that don't exist, that have retired, that have moved away, etc. And I know that this, is difficult, right? I think CMS estimates, right, 45% of those entries have some sort of inaccuracy in them. Could be pretty small, could be pretty glaring, right? These are a couple of headlines that I've found, in the past few years or so about some of the financial and, even care-oriented consequences of this, these gaps in provider directories. But definitely an issue that is noticed by the public, that is maybe experienced by probably everybody in this room at some point. And it might just happen so frequently that you may not even remember it, right? But this can really, really trip up folks who are already having a tough time finding care. All right, so in terms of provider directory, this is the product that InterSystems makes, and there are other products that that work as well. Of course, I can only speak to the InterSystems approach here, but I wanted to talk about how we get a lot of the different information that goes into those records, right? So how do we find out the addresses where a provider practices at? How do we find out, what credentials they have, if they are active, maybe if there's any sanctions against them? Things that are both internal and external facing, right? So not everything is going to be put on a public find a doc page, but maybe there's other things that you need internally for your personnel management or other network management issues that you're having there. So I'm going to talk about this sort of approach of how we get data into our system and what we do when it's there. And I'll talk about these in a little bit more detail as well. So first we ingest this data, right? It comes in all sorts of formats, right? Could be as simple as a CSV file, NPES, which is the National Plan and Provider Enumeration System, right? That file from CMS of all of the providers, in the country who are able to treat Medicare patients. And real-time updates, right? So we're not just taking files in batch, right, or in bulk. As they come in, we're processing them and organizing them and cleansing them, right? So not every data source is going to be great, right? That doesn't mean it's entirely useless, but we also want to make sure we're catching any sort of data quality issues that come in as close to the source as possible. And if not, also at the source, right? We can only deal with what we have. We can't really change the organizational practices of all of our sources as much as I'm sure some of us would like to. But we can certainly have a quality gate, make sure that what is coming into our system is as accurate as possible and isn't going to sort of poison the well. So, any obvious data quality issues here, if that there's certain things that might arise, based on your previous working with the data, you can have custom validation rules as well. If you know that a certain source, inputs dummy values for social security number. Let's say they put 9 ones instead of a real social security number because on some form somewhere, it's required, but they don't actually want to collect it. You can treat those values as null and not include them for the purpose of matching and organizing this data. And duplication, right? So we get a lot of duplicate records coming in, right? Sources will say, hey, I'd rather just send you everything I have and not worry that I'm going to miss something and be a little overzealous in how I deduplicate it. We'll handle that at the front end, right? It just improves, streamlines some of our performance issues there. And then map. So I'll talk about this in more detail in the next slide, right? But, or in a couple slides, but the actual entities that operate within healthcare are complex, right? The relationships they have are complex. It's not just as easy as an Excel spreadsheet of every doctor in your system, right? They have different organizations, different plans they're part of, different specialties, potentially different addresses they work at. They might practice at a location and then, bill from a different address. Who knows? So we're able to map those to sort of reflect the place in the healthcare ecosystem that each of these records is associated with. And then match, right? So you get records from all sorts of places. Potentially that NPES file has, information about the provider. Of course, the hospital that they work at might have information, personnel files, credentialing systems, things like that. And then you might get some other sources of information. So including, provider actually entering information themselves. Let's say they want to include their latest hours of operation, right? There's no magic NPES file that's going to know that better than the actual provider who's choosing those hours of operation, right? But being able to actually match and ensure that, the John Smith we see from this NPES file is the same John Smith that we see from our hospital personnel file who actually inputted their operating hours. that those are all the same person, and those records unified under one enterprise ID is important. And I should emphasize too that this isn't just about individuals, right? We have a similar matching process for organizations too, right? So some of these organizational definitions can get very complicated, especially as you get bigger and bigger in scale. So potentially those organizations might have subsidiaries or other spin-off groups, right? And we're able to actually match them across different data sources as well. And then master, right? So we're all here because we're interested in accurate provider data, not just, an aggregate or let's say a pile of provider data. So being able to actually build that golden record, build that single source of truth where we're saying, okay, this is what we have. You can choose what you need, but it's all going to come from this latest and greatest, best known record, right? And that comes from, a series of business rules that are built in as well as customizable, right? And then being able to track some of the historical updates to records over time as well. And then sharing, right? So we want to be able to share this out with, a public-facing website for Find a Doc. We're also, we push to FHIR for the DaVinci PlanNet IG compliance. We have a data steward portal UI that allows sort of internal users to actually look at and curate the data, understand where data may have been updated or changed. If there's an issue, they can easily sort of identify the source of the issue through that user interface there. That's not really meant to be, a nice and sort of public-facing UI, but it's certainly important for these users internally as well. So those are all ways that we share this information that we have accumulated and sort of built into that golden record. So yeah, I think I alluded to some of this earlier here, right? But the data that's coming in, right, is coming from all of these sources that really it's not possible to unify in any other point, right? Some of these are being generated by the provider themselves, right? In case of operating hours, maybe languages spoken, things like that. Other things like credentialing may give you, any sort of certifications, specialties, etc. And then, any sort of larger organization, right? NPES or CMS being one. There's many other authoritative sources that are also able to be included here coming in, right? And so that data steward portal is what I mentioned for internal users to be able to sort of view what's going on behind the scenes and kind of understand the algorithm or the mechanisms that provider directory uses to create that source of truth. And then everything coming out on the right is what is actually being shared. So that's that mastered record, that golden record, single source of truth there. So kind of all the magic is happening in that kind of central cloud icon there. Right. And then again with the linkage here. So this is, just a quick example of two records for, what look like two very similar people, right? John Smith and then Smith, comma, John. John spelled slightly different. I see NPI maybe slightly different. Social or phone number is, off by 1 digit, something like that, right? And then with provider directory, you're able to make a determination using your own business rules, your own organizational risk tolerance and priorities to actually build out a model that will determine whether or not these are the same person. If they are the same person, they're assigned to the same enterprise ID, right? So that's that EID 10001. If not, they're assigned to different enterprise IDs, right? So there's no no confusion about whether or not the decision has been made there, right? And this is all customizable. So all of the logic that goes into how these links are made is entirely controllable by the user, right? So they're able to go in and say, hey, I know my data, I know my sources, I know my own, risk tolerance for false matches, right? That's two records that are given the same enterprise ID, but don't actually belong to the same person or organization or whatever, right? I know that I really do not want those. Those will mess up my system. We'll be sharing wrong information, mixing up addresses. It'll be a mess. You can control that as well to make sure that you're actually getting a true reflection of the state of these records. And then this is sort of that mapping that I was alluding to earlier here. So, providers don't just mean individual providers, and they definitely don't just mean doctors and nurse practitioners and physician assistants, et cetera, right? We're kind of in this slow but steady, we can debate that transition towards value-based care, or at least with an eye towards value-based care. A provider could be somebody who does patient transport, somebody who drives patients to their doctor's appointments, right? Could be someone who does lawn care, right? For an elderly person who's not able to, right? Some of these plans have, very kind of what you would think of as out of the box benefits that may not have existed, a couple decades ago, right? No one would have conceived of those as providers. But in that value context, we really have to have a data model that's able to flex to sort of support that expanding definition of what counts as a provider in the healthcare system, right? And also, right, not just individuals, but organizations, the organizations that provide that care, where they practice at, where they physically live, right, your personal residence, right? You maybe don't want to share that on your public facing site, but it's certainly something that your organization needs to note, right? Your physical or mailing address, what networks you're a part of, for what period of time are you a part of those networks, what plans are part of that, who administers them, et cetera. So all of these things kind of bake into this really tough and tangled web. And it can get pretty complicated to understand the difference between some of these sometimes. But that's what provider directory really helps to tease apart those differences, and then also actually highlight the hierarchy of how these relate to each other. So giving you a little bit more visibility into that tangled knot there. And then we end up building this golden record here. So there's kind of a lot of information on the screen. I'm going to try to walk us through this here. So everything on the left is that master record, right? So this is sort of the fully realized golden record. This is our best set of information that we have. This is what's going to be shared out, right? So this is what's actually leaving the provider directory system to actually make sure that we're sending that accurate source of truth. We've broken down those silos appropriately. And then here are the silos here. So these are different, sort of example clinics. You have East Care, you have Echo, you have West Med, et cetera. And it gives you some information, right, of, here's when it was brought into the system, here's when it was last updated, et cetera. But these have all been determined to be linked together, right? So these are all contributing to this master record. So we're on this contributing record screen here. And we can see that this person has been assigned, an enterprise ID. We know their best, NPI number, et cetera. And then there's a couple different variations, between the sources. So this Frederick Johnson probably goes by Fred. He's a junior, but maybe doesn't include that on, all official, writings out of his name, right? Maybe certain sources only have him as, no junior, no indication of a suffix there. Right, but based on the trust tiers of this data, right, and the freshness of this data, so the timeliness of this data, we're able to sort of assemble kind of a composite record that builds up from the best of all the sources that we have. So of all the information we've contained, we've taken sort of the best address, right, the best NPI number, the best, I'm trying to think of another one, employee ID, something like that, right? So your employee ID probably is most trustworthy coming from an employer record, right? You might have it written down in some other source, but you might have a typo, something like that. It's not going to be as close to the source of record as possible, right? So that's why we actually allow this on a parameter basis, right? So you may say, hey, something like my full legal name will probably be more accurate on this source versus that source, right? Versus my telephone number, my latest mailing address, things like that might be from a different source. So we account for both the trustworthiness of the source at the particular parameter we're talking about, as well as the timeliness and the freshness. When was the data last updated, right? Is this something from a year ago, or is it something from 5 days ago, right? And depending on that, we can actually determine a trust tier based on what we have there. So that's how you get this, best possible name, tax ID, and PI from across these different sources. So that was really what I wanted to share with you all today. And I can go back to the Zoom screen here and just see if there's any questions that I can answer for you guys. Again, I'd love for this to be a more collegial discussion here. So please feel free to just throw something out and I can react to it live if you would like to see that. If not, I'll make Michael make up a question on the spot.
Actually, Kristen, I do have some
Oh,
questions
perfect.
yeah, directly sent over to me on the chat. Besides avoiding the fees, penalties for inaccuracy and attracting new members, do you ever see a purely internal operational push for better provider data management?
Yes. So besides okay. So besides I guess besides the carrot and the stick, right? What's in it for the guy in the middle, right? That's at
Hmm.
least how I'm interpreting this. So yeah, I mean, definitely. So certainly, right, there's many carrots, many sticks. And I think hopefully we've discussed that in detail there. But definitely there's a benefit to kind of your internal folks too, right? Your IT team, any of your operational teams there, really a business strategy team. Again, it'll depend on the organization, but consider the example, right, of, underutilized providers, right? You have some people who you have a wait list a mile long to see the specialist, and then you have, the same specialty, a new person moves into the area, becomes in network, and suddenly they're available to take patients, but, they're not being filtered to the top of these find a doc services, right? So maybe there's an opportunity there to prioritize the search results, right, for your users to make sure that they're sort of being steered towards or given the option of choosing a provider who is more available, right? And that can certainly help with internal operationalizing of your strategy, making sure even coverage, identifying any care gaps, right? So if you have gaps in your network coverage, right, you're missing a certain specialty, something like that, you can certainly include that too. So I think also in general, right, you have all these data sources coming in anyway, and you might have, as an organization, made a significant investment previously in having, whatever your credentialing system was, whatever your personnel file, your workday system, let's say, right? All of these other systems of record, and actually, trying to rip and replace and create something that is inclusive of everything, from scratch, sort of tosses out all the investment you've done previously, right? So it's not a question of having to rip and replace every other source system. You can actually just sort of apply this harmonizing layer on top and hopefully make it easier when it does come time to, arbitrate, you get a complaint that, oh, my provider data is wrong on this application. You can go in and really easily figure out what went wrong there and correct it at the system instead of having to, potentially make changes across sources. Hopefully that answers that there.
Oh, great response. Eric has a question in the chat. Has AI been used to clean up provider directories?
Yeah, great question, right? I think AI has been used, at least tried in almost everything these days, but yeah, certainly, right? So, in terms of cleaning it up, right? So, I think the biggest consideration here is no one knows your combination of data better than you and your organization, right? So, there's always little quirks with how every organization collects data and really how every source collects data. And then the standards that your organization has for how you're going to assess accuracy and present it out to the world, right? So certainly, there's definitely been AI that's used to clean up, let's say like, yeah, address formatting is probably an easy example, right? So there's, at least in the US, there's a set of standards on what are acceptable USPS postal service, valid addresses there. So AI is definitely used to quickly match, let's say something as simple as, formatting this address into something that is is usable and correct and easily compared so that we're not missing out on links that should be had just because of really strange formatting with the address. And then go all the way up, right? So you can use AI to search through a bunch of provider directories that are available online, right? If you have a user, who's just saying, I just moved to this new state. I need a primary care doctor who meets my long list of criteria and is familiar, with this long list of criteria that I care about. You can certainly do that too. And we've seen that more and more as well. Should I
Excellent.
just go
Thank you.
down the list, Michael? I see a couple more questions in here.
Sure, if you'd like to. You
Sure.
can read them off if you'd like. Go ahead.
Yeah, so let's see. Carmen, you've asked, how do you weight the quality of the data coming from NPEZ? Is the last update timestamp the driving factor? So it can be, right? So within NPEZ as a source, right? Typically the latest update from that source is considered the best, right? So if I told you something last week, don't quote that to me if I told you something different yesterday. The yesterday is probably right. Um, However, right, how the NPEZ data is weighted against other data sources is going to be up to the organization, right? Now, for some things, we find that NPEZ is really good at reporting, right? But for others, depending on where you're at, depending on what state it is, it's even it might not be the best choice for your organization. You may just want to have it listed, but you don't actually want it to ever supersede any of your other internal data sources in terms of accuracy. But that's a personal or an organization's own choice of how much they want to give credence and weight to the NPEZ files there. But it's not just the timestamp unless it's within the source. Okay, and then here we go. On building the trust of the sources, do you start with parameters on how trustworthy sources are, or are you expecting everyone to grade all sources themselves? If you have conflicts around sources of truth, how do you help the user resolve? Make sure I got that. Do you start with parameters on how trustworthy sources are? Yeah, so it really, I would say that a lot of it does come from what the organization wants, right? So there are some built-in tools that allow you to kind of rank what we think is the best quality of data, but that's always able to be superseded by, the authorized user or the organization's priorities themselves, right? So that's a custom rules that are coming in. It's going to be source specific though, and it will also to a certain extent be use case specific, because you might have different data points that are inaccurate from these sources, but you really don't care about them, right? You're not using them in any of your downstream applications. It doesn't necessarily matter so much that, this is going to make this source less trustworthy overall on the things we do care about, just because it's not trustworthy on the things we don't care about. Let's see. From another question, have you used data from CMS's Medicare physician and other practitioner lookup tool? If so, how reliable do you find that data? I have not personally looked at that data source there, but I can certainly make a note of it. And see, I don't think I have a great answer to that, to how reliable I find it, just because I'm not super familiar with it right now. So sorry about that. Does the data model include delegation status of a data source? If so, what role, if any, does it play in terms of data scoring or determining the golden record? Does the data model include the delegation status? David, is it possible you can clarify what you mean by delegation status in this context? I don't know if David is. Oh, we go. If you want to come off mute and clarify, or just put in the chat. Oh, perfect.
Sure. So this would be the as far as like credentialing. So the if the an entity submitting data is delegated, say, with a payer receiving that data. Right. So if you're sort of delegated, you're handling credentialing on your own. The payer sort of delegated that to you, and you're submitting data versus not being delegated, and whether or not that plays a role in how the receiving entity may determine the quality of that data.
Yeah, so outside of just the ability of the organization to control the relative trustworthiness of a source, right? Or to say state what that relative trustworthiness is. There's nothing out of the box that's going to know that because it's from this specific credentialing source that's been decided, it's going to be better. But again, that can be configured by the organization itself.
Thank you.
Yep, thank you. And then let's see, what defines the business rule for creating the master record and who validates that business rule, right? So it's a set of business rules, right? I say rule is kind of a, I don't know, capital R, type of rule. It really is a combination of factors there. Who defines it is going to be the organization themselves, right? So the organization at the end of the day is the one who needs to use the data. They're the ones who are kind of determining what the single source of truth is, overall. So they will be the ones to do that and also to validate it themselves, right? I would say probably the person who is involved, or the team that's involved in defining those business rules, will also play some sort of role in, either doing the testing and validation of that themselves or overseeing a related team that does, is typically how I've seen it. Let's see. How do you handle roster files for large provider groups that exceed 1,000? So, I mean, there's no specific limit on the number of provider groups there. Is the question, Michelle, that around like scaling and performance, or is it more, is there a difference in the format in which it needs to be submitted for what seems to be like a bulk load? Is Michelle still here? Oh, difference in the format for bulk upload. Not really. So there's a couple different ways that you can ingest the data, right? So on a continual basis, right? It's coming in, and obviously the files either are full record updates or they're just sort of deltas between whenever the last time it came in. But really, it's not handled any differently from a technical level. It's just either more files or larger files. You can do it sort of both ways depending on how you're getting the source data and what works for you. Great, thank you. All right. Any other questions? Anyone want to be brave and come off mute? I hate it when people ask me that, so maybe I shouldn't ask for you guys to do that. But definitely great engagement in the chat. Michael, was there anything else?
Sure.
I don't know.
I got one here. One was direct message to me. When you match
Yeah.
these different records together, what factors do you look at to determine if they're the same?
When we match the records together, what factors do we? Yeah, so it could be anything, right? I think some of the obvious ones that I would look at for an individual provider are going to be, well, their name, NPI, any credential, the assigning authority of those credentials, the range in which they're active. Those are all taken into account. Potentially things like email, we find to be pretty predictive, right? Things like phone number, it depends, right? Organizations as well, it could also be NPI. Tax ID tends to be a good one. It does depend. And then, of course, the data model is extensible as well. So you could also link on something that's, kind of a little bit more of a wild card, right? If there's some specific identifier that your organization has already assigned, or already knows about, those can certainly be done there. And the relative contribution weight, right, to the overall sort of determination of are they the same or not can be controlled as well, right? So we have a starting point that we give you, right? We have kind of a here's what's worked for us in the past, or here's what's worked for us with a different customer. But for the most part, it really is going to depend on the type, number, and quality of the data sources that are coming in and just what fields are available for you to choose from, right? I wouldn't want to say, oh, everyone should absolutely use address when, maybe half your sources don't include an address for whatever reason. So it's definitely not a one size fits all. We do provide like a starting point for most people that works fairly well, at least without more than, a couple minor tweaks.
Sounds good. Raj, who originally had a question in the chat, has a follow-up question. I'm going to unmute right now.
Oh, yeah, please.
Hey, good afternoon, guys. Good afternoon, Kristen. Thank you for the your presentation there. So you mentioned about a client has to give you the business rule. So I was trying to kind of understand, what is your product? Is your product a software, kind of an engine, and the back that is kind of running, where I, as a client, if I'm buying your product, I have to give you the business rule as to how my master record is going to look like. I have to validate the business rule based on whatever the CMS guidelines, whatever kind of the CMS or the state kind of Medicaid systems agencies kind of tell, which will be an accurate record. So are you saying that that is on the client side, client's responsibility to provide you, and your side is only your system will take all those business rules, and it's like a software that will kind of generally kind of take all the business rule and kind of pump out a master record? I was thinking kind of your product will probably take all the source data. Of course, I have a question on how you get all the data from all the different sources, because I don't think there is a blanket approval of getting all the data across the board. But once you get, I was thinking you will kind of figure it out. You'll have that kind of business rules and logic to find out data coming from multiple sources to identify which one is the standard record, which one is the record master record. What I heard you say was you are waiting for the clients to kind of give you that business rule of what a master record should look like. Is that a correct understanding, or did I misunderstand anything?
Yeah, no, I think that I think the later way that you described it is accurate, right? So in the sense of if you had a single source of truth that you knew to be perfectly correct, right? Then there's no need for a provider directory software on this, right? The issue is when you don't have that single source of truth and or anything to compare the accuracy of to, right? So you don't necessarily trust the whatever is coming from CMS or wherever, that doesn't exist in a way that is functional for your organization, right? So you have to build it with what you know about the source data that's coming in, right? So what you know about every individual field on every individual source and how to actually choose what's best. So there's logic within the product that helps make that determination. But of course, everything is subject to, the organization's approval, and they're able to make modifications to that logic as they see fit if they need to. So I apologize if that was unclear.
Oh, no, thank you. And kind of just a follow-up question. Do you have any partnerships with any of the state Medicaid agencies or payers? If so, can you please share?
I don't have anything that I'm able to share with you right now that's public for that. That would be at their discretion if they're willing to discuss that with you guys.
I mean, you cannot share who your clients are?
So we would need approval from them to make sure before I go, reveal to a public audience. I'd want to check with them and make sure they're happy to be mentioned.
Thank you.
Yeah.
See if there's any questions. I do see something in the chat. Bill has a question. How does this play with the idea of a CMS run directory?
Yeah, good question, right? So if you're following this space at all, right, CMS National Provider Directory, is looking much more possible than it did previously. So definitely an exciting turn for us there. The question really, I think, is, how is CMS going to maintain such a large directory, right? How are we going to be able to get everything updated, everything filtered in across such a large scale, right? So, it's still kind of TBD depending on the outcome of some of those early pilots there of how they're going to want to structure this. But it's my, guess, right? Again, my guess is good as anyone else's, right? That there's going to be, a significant burden or requirement placed at the lower levels, right? That are just going to be accumulated up to a national sort of single point of access. But the responsibility for actually obtaining, updating, curating the data will still probably fall at a more local level, right? And local could mean it could mean the state, but it probably would be even more granular than that, right? Potentially by a single provider organization has more scrutiny on their ability to deliver that provider directory information and data accurately.
Excellent. Thank you. All right, any more questions? Please enter them in the chat.
If not, no worries. Thank you all so much for the great discussion. And please feel free to email me with any sort of follow-up questions there. Thank you so much for your time.
Thank you, Kristen, and thank you once again to InterSystems, the sponsor of this spotlight. Everyone, have a fantastic day.
Thank you all.